So, so there are lots of different things that we're going to talk about today, but the lecture is advanced injections and minimally invasive options for a better back. Pain has many different purposes. If you go back in history, right? Pain used to be a tool used by emperors and kings and monarchs. The Romans used to use it as a sign of power. So they would torture patients and people. And if you look at the Tower of London, they have a whole torture room in England. Essentially what it is it was used as a tool to frighten people. Now, in the modern world, we have athletes and philosophers who use pain as like a marker of strength. So pain throughout history has had many purposes. It's a force that's in multiple cultures, and it's one of those things that affects. All right, so pain affects individuals, obviously, but it's also one of the biggest problems in society. There's the number one reason people go to the emergency room. Number one reason people are in disability, suffering. And so pain affects us today as much as it did back 100 years ago, even though we have so many new technologies and we have learned so much more about pain. The big thing to realize is that we have acute pain, all right, and then chronic pain, two different diseases. I wish they'd named them different things, right? So acute pain is something with a beginning, a middle, and an end. It's treatable. Chronic pain, there are a lot of cellular changes that take place that make it a very different disease. And chronic pain needs to be treated differently. Now, you probably heard of this opiate epidemic people talking about, so we never knew about addiction and tolerance and dependence and abuse and all these different things as the physicians in the 50s and 60s put everybody on opiates, right? So that was a problem. And now the pendulum is almost going to the other side where they're not giving anybody pain medicines. So definitely a problem. Now, when we talk about treating pain, there have been many strategies throughout medicine in the past 50 years itself. Surgeons operated, physical therapists did their thing, chiropractors worked separately. All these different specialists were siloed and didn't get good results. So modern thinking in the early, last 10 years is to have a pain center where all these different treatments are offered to one patient, and that gives them the best outcome. So if somebody has pain, the way to be successful is, well, first we got to get them comfortable. You get some medications. Muscle work, so important, right? And physicians are guides. People come to me and, we have a lot of different tools, but the muscle work is something that I always tell patients, you got to do it. It's on you, because what happens is that if you have a problem in your back, you have to strengthen all the muscles in this area. And that is a daily job. Behaviors, have to look at your behaviors. Is there something that you're doing that causes you pain? Now, let's say you're golfing and you like to golf. We don't want you to stop golfing, maybe change it. Do things you like, but evaluate your behaviors. Alternative treatments, there are some treatments that have a lot of evidence, like acupuncture has evidence behind it. Bloodletting, not much evidence behind it. So you want to do the things that have evidence-based medicine, right? And today's lecture is really more of the direct treatments. And the reason I put this slide up here is I don't want you to think that it's just one thing that fixes it. When you're in that stage of intermittent chronic pain, which is what we like to get, as a solution, meaning when you have a chronic problem, we want to give you periods where the pain is gone and you can do things you want, live the way you want, because pain affects you physically, but eventually it can affect the way you feel and change your whole life. That's the danger with pain. So this is a very important tool that revolutionized a lot of things. I'm going to use this keypad, my little mouse here. So this is called a C-arm. All right. When this thing was invented, it changed a lot of treatment options. Right here, you see a patient laying down on the bed, right? This is a physician. And this C-arm device allows us to take pictures in many different angles. So that was a huge revolution in the way we treated pain. With this device now, we could put medicines within millimeters of our problem areas. So this essentially transformed a lot of treatments. And we're going to talk a lot about the C-arm and how it is used in today's care. So I want to keep things simple. So we're going to talk about two things today, all right? We're going to talk about where we go to put medicine, okay? The where and the what. That's my whole talk. Where are we going and what are we putting in there? So let's start with the where. The two most common places that we go to for medicines, one is the epidural space and the other one is joints. Pretty much 90% of what we do, or 95%, is putting something into the epidural space or into a joint space. So let's start off with some basic anatomy here, okay? So if this thing works, all right, so pretty much what this is, we're talking about some anatomy here, and if you look, right here is the vertebral body, right in the middle, right there, okay? And so when you stand straight, people thought there was one bone in the back. They called it the spinal bone, or the, have a backbone. But as time went on, we've learned that it's not just one thing. It's a very complicated structure that protects your spinal cord. The spinal cord is very, very delicate. And right there, the vertebral body. It looks like a brick, okay? That's a side view. And there's a ligament in the front. We'll get rid of that. And the vertebral bodies are stacked on top of each other, like a brick would. That's the second vertebral body. In between these bricks, right in the front, is a disc. So that's the blue one is that right now is the vertebral body, is a disc in between the vertebral bodies. And that gives you cushioning. All right. And very important to kind of get an idea about this anatomy, because we're going to talk about where we put medicine. Now, we're going to turn this model to the back. And if I'm looking at you from behind, that's what it looks like, all right? So this vertebral bodies, as they're stacked on top of each other, that is the lamina. And in between those two is a little line, and that's the joint space called the facet joint, all right? So in the front, we have the discs, and in the back, we have the facet joints. Now I'm removing a vertebral body, and we're going to look right in the middle, and you can see those are the two little joints, the superior and inferior articular joints. We call those the facet joints. They connect to each other. So as we go close here into the canal, you will see the opening in the back where the spinal cord goes right through. And that's, we're getting rid of more ligaments just because we can. But and there's the spinal cord. So if you look at it from this angle, we're looking at it from up. There's the disc in the front. That's the spinal cord and the facets in the back. And so this is the complexity of the vertebral bodies. And why do we have this? Well, this arrangement allows us to bend, twist, walk, and move. Unlike what we thought before, we don't have one backbone. We have these segments that allow us to move. And it's very important to have this because the brain and the spinal cord are really the only organs in our body that don't regenerate. So if you think about it, if somebody has a stroke or a spinal cord injury, it's pretty permanent. If you have a broken bone or you have surgeries, you can regenerate. Now, that's why you have this complex protective system in your body. So now we're going to talk about the epidural space. And there's a lot of confusion. People think about the epidural as an injection. It's really a space. So we're going to go to the back. So that's the back and the front. And we're going to take a closer look at this lumbar spine. So we're going to take that's the lumbar spine right there. That's a side view. The yellow structures are the nerves coming out. And if we get a closer look at that, all right, so I'm going to kind of cut it in half. This is sagittal view, all right? So right in the middle right there, that's what the spinal cord looks like. Okay, and that's the dura. The dura is a protective layer around the spinal. It protects the nerves. And the epidural space is right above that, epidura. So if I'm doing an epidural injection, we first numb the skin just like that from the back, patient's laying face down, using a C-arm usually, and a needle is guided in right into that space above the spinal cord. It's usually millimeters. In the low back, it's 5 millimeters. In the neck, it's about 2 millimeters, so very narrow. Now what we're injecting is a dye. It's a contrast dye that allows us to visualize the epidural space. And this is what it looks like. In a second, you'll see what it looks like on X-ray. Oh, not. Okay, so essentially the epidural space is an area right around the spinal cord. So that's where we go to put stuff, right? And that's what we're going to talk about, what you can put in there. So let's talk a little bit about the discs, though. In the front, you have a normal disc right up there. Degenerative disc. Essentially what happens is due to three main reasons. One, genetics. Two, activities. Three, injuries, right? These discs can change. Essentially, the cushioning that we have when we're younger reduces and it can become a degenerated disc, or it can bulge into the canal, or you can even have a herniated disc. Now, a herniated disc is interesting because if you look here, right, think of this as a jelly donut. I love donuts, don't eat them much, but the jelly gets pushed into the canal, right? And that's the herniation of the disc that causes all these problems. Thinning disc, sign of arthritis, and finally osteophyte formation. What that is if you look here, these little bone spurs. So when the disc pushes on each other and it collapses and it becomes bone on bone, it forms little projections and little spurs like spearheads. So essentially these two things are pinching the canal, right? The bulging and herniated disc pinches a canal. This is arthritis. So the two main conditions we deal with is pinching of the canal, known as stenosis, or arthritis, which is called spondylosis. And this is on an MRI finding, if you can see right, well, this is not working, but right here, you can see right here, okay, there's a little gel coming into the canal. So if I come across, that's your spinal cord coming down like that, and you see that that's a herniated disc. And this is L5S1, and that can cause a lot of problems in your back and legs. And so typically that causes sciatica. And sciatica can have a lot of different symptoms. It can cause numbness, tingling. It can cause a burning sensation. It can cause weakness sometimes. And in medicine, we like to, sound important and confuse people. So there are 10 different names for the same thing. So when you hear the word herniation, stenosis, all those are ways of describing a narrow canal. And all of that can cause sciatica. Now, this is a picture. This is a front AP picture. This is a side view. And you see all that black stuff in there? All that's the dye. This is the needle, okay? And if you look at it from the side too, there's a needle coming in here. And this is contrast dye, and that's the epidural space. So the epidural space is highlighted with contrast dye so that when we're doing an injection or something like that, we can visualize it very clearly. And you can put anything in there. That's what I'm getting at. You can put, and we'll talk more about this. All right. This is a side view. So there are two ways to get to the nerves. From the middle, that's called inner laminar epidural. This is from the side. It's called a transforaminal epidural injection. So this is a nerve root. And this keeps going down and it forms a big clump of nerves and it goes all the way to your foot. So that's why when the nerve's pinched up here, you feel it shooting all the way down to your legs. And each nerve coming out of this goes to different areas. So L1 goes here, L3 goes here, L4 goes across the leg. So that's why when we look at you and ask you where your pain is going, we figure out which nerve is pinched, get an MRI to confirm it. So that's the epidural space. Now, the second thing we inject is joints. Lots of joints are injected. So let's have a look at this guy. He's standing up like this. We're going to look at his pelvis. Okay? Let's get a closer look at that. And when we get close to the pelvis, we see the hip joint. Now, a joint essentially is two bones connecting to each other, right? And we have every single joint, most joints, you have a cushion, you have some fluid, and that's true for the hip joint. That's true for the sacroiliac. So this is the sacrum. This is the pelvis, sacroiliac joint. And up there, we have facet joints. Now that's in your low back. So these are the three main joints that we work on people with back pain. Again, this is a needle going in to the space. And that's how I know I got, so when I'm doing injections with x-ray machines, I know I'm in the space because of this. That's a joint. So this is a very unique dye pattern in the joint and tells me exactly where I am. So once we get that dye pattern, now we put whatever we want into the joint. And that's an SI joint. You can see it outlined right there. Now let's talk about the facet joints. Those are very, very common causes of back pain. So the cervical is in the neck, thoracic is mid-back, and lumbar is obviously the low back. And those vertebral bodies stack on each other all the way from the neck to the tailbone. So every level is a joint that moves and twists. Now this again is a side view, right? So this is how it connects here. And if you look at the joint, this is an arthritic joint. It's got the osteophytes, the little bone spurring, and this causes a lot of pain. So even the facet joint, which is a very, very small joint, has all the features of a hip. It's got cushioning, fluid, and all that stuff. And we call it spondylosis. Degenerative disc disease, spondylosis, again, fancy words for arthritis. Spondylolisthesis, just to confuse you, sounds just like spondylosis, but it's different. It's a little movement of the joint. Essentially, the one segment moves in relation to the other one, pinching the canal. And so this is an X-ray image of, that's my needle, that's me in the facet joint, lumbar facet, L45. All right, so we looked at the two wears, the joints in the epidural space. Now, what do we put in these joints? There are a lot of choices. Steroids, most common, we'll talk about it. Heat, we can put in heat. Electricity, platelets, stem cells. These are the main things we can use in the epidural space or joints. So again, this is so when somebody comes in, the way we decide what we're going to put in there is really based on the diagnosis. For instance, if somebody comes in and is in labor, we go to the epidural space and we put fentanyl and bupivacaine, pain medicine and anesthetic. If somebody has sciatica, we go to the same space, but put a very different medicine. So based on the diagnosis, based on the history, exam, imaging, testing, and patient goals. Very important to figure out what patient goals exist. If somebody wants to, sit around and do nothing, don't encourage that because that's not good for you physically, mentally, it's bad, but maybe you don't want to cut down a tree every day. So somewhere in between, we get some goals and then we decide what stuff to put in there. The most common though is steroid. Let's talk a little bit about steroids. We're not talking about anabolic steroids, right? That's the bodybuilder steroid. We're talking about corticosteroids. Corticosteroids are substances released by your own body, and it's an anti-inflammatory medicine. It's all over your body. We can use this for allergic rhinitis, sinusitis, inflammation, anti-rejection medicine. So steroids are used every single part of your body. And the advantage of injecting steroids over taking it orally. So if you take pills by mouth, it goes through your liver. It does a lot of things where you have byproducts that can be toxic and have a lot of side effects. But the advantage of using an X-ray machine and getting right to the spot, the steroid doesn't change. You get 100% effectiveness in the area without the medicine getting digested. So lots of different types of steroids. We've got depomedrol, methylprednisone, okay? And where do we put these? Epidural space, joint space, all the time. So steroids are the number one thing that you get injected with. What about heat? Well, this is a procedure called a radiofrequency rhizotomy or an ablation. So yeah, so this is the joints, right? We go around the joints and through the needles, I connect a little wire and the wire connects to a little machine. And then I can do a bunch of stuff, but essentially burn the nerves. Now, we're not going to burn your spinal nerves. Again, it has to be in a very specific area we put this heat. And so this is a physician performing this procedure. Here's a patient laying down, right? That's the C-arm. And these needles come out of your back. They're connected all the way to that machine. And through the machine, you can test sensation, you can test motor, make sure it's in the right spot. And you put heat. And usually we put a lot of heat, something like 180 degrees Fahrenheit in each nerve. So Yeah, a little bit. So this is another picture of somebody up close. And this is what it looks like on X-ray. So here's the lumbar spine. Those are my needles. That's the connection right there. And we burn those nerves. And usually the nerves stay burnt from 6 months to about 6 months, but that's the trick. So remember we talked about that comprehensive plan? So once the nerves are burnt, you're able to do more exercises. That's the goal. So whatever we do, say an ablation or anything like that, you need to strengthen the muscles after that. Because if you do a good job strengthening the muscles, when they grow back, you're in a better place and may not be in that much pain. This is done for knees. In Europe, they're doing it in shoulders, elbows. It's not authorized in the US yet. But this ablation procedure, here's somebody sitting right there, and we're putting needles into the knee around the 3 genicular nerves, and you can dissolve them there. Electricity. So we got steroid, we got heat, now electricity. Essentially, electricity is used in the epidural space mainly, but it can be used in the joints. So these are 2 wires, all right? I'm going to put it right in between this opening. And this is somebody, remember in the anatomy we saw, this is the back, this is the lamina. These are the facet joints right there, okay? So the wires go in there and they stimulate the spinal cord through the epidural space, right? So this spinal cord stimulation, what it does is it prevents the pain signal going to your brain. And you can use it peripherally. So this is called a spinal cord stimulator. And this is what it looks like when it's implanted. 2 little incisions and the wires go in there. That's what it looks like on X-ray. So you can see these are my 2 wires in. Each of these are little electrodes. And they're really fancy. They got Bluetooth stuff now. You know, you get 5 different companies, and they can adjust it through wireless programming to talk to each other or send the stimulation in, outwards, all sorts of fancy stuff to essentially block the pain signal. And over the past 5 years, we've seen an explosion in this technology. So they have different leads now. This is called DRG, where it goes to a different area in the spine. And they also have these kind of external devices. I'm sure you know this guy, Joe Montana, right? Quarterback, famous guy. He's retired and some knee pain. So what he did was he got one of these peripheral stimulators in his knee. So what they do is they put the wires in here, okay? So these are the wires. They're permanently placed next to some specific nerves. Now you can have the option of a battery, which it'll continuously, it's like the size of a pacemaker. It'll continuously give you some stimulation. Or there's something that's called NALU. It's a newer one where what he does is you have a little bit of a bump under your skin where this electrode sits. It's really, you don't even see any scars. Then he'll hold this disc over it for like 15 minutes to 20 minutes every morning, and it'll stimulate the nerves, and he's good for the rest of the day. So this NALU technology is used mainly for joint pain, not so much low back or the epidural space, but more for joints. All right, so we looked at steroid, heat, electricity, platelets. So platelets or platelet-rich plasma is, one step kind of behind stem cells, so to speak. It's a way of tricking the body, right? So what we do is you come in and we'll draw your own blood. Then we spin the blood, and the blood will separate into the different parts of it. One has platelets, one has plasma, and one has the red blood cells itself. And what we do is we take the part of the blood that's full of platelets. Now, platelets are responsible. So if you cut your arm and it stops bleeding and it'll clot up, that's because of the platelets. What the platelets do is they send a signal to the body to send in cytokines and growth factors and all these healing stuff. So we take these platelets from your own blood and put it wherever we want with the X-rays in the epidural space or in the joints, and that tricks your body to send healing elements there to help heal the area. So platelet-rich plasma is getting very, very popular. Lots of studies about it, very successful. It's used, some practices almost exclusively platelets. They don't believe in steroids. They almost think that steroids can damage the body. Not really. So people are moving a lot towards platelets. And the final thing I'm going to talk about is stem cell. Okay. So stem cells are getting very popular. Okay. So what is a stem cell? A stem cell is let me point here. So a stem cell is something that is able to change. Okay, it has the ability to change. So this, you can see, it's called a mesenchymal stem cell, right? So it's a cell that can become bone, muscle, fat, cartilage. It can become all of that. Now, there is not much evidence that it does that. But eventually, I think 10, 15 years from now, I think we'll be able to put in the stem cell and it'll regenerate cartilage. Today, there's no evidence it does that, even though lots of people claim it does. But what stem cell really, they're able to do is it reduces inflammation, fights cell death, it can replicate. So it's kind of a stronger version of the platelets, right? And there are 3 different ways to get stem cells. One is your own bone marrow. So what you do is you come in, we lay you on the table, numb this area up and take a little bit of the bone marrow, spin it, prep it, and you can put it in, again, epidural space, joints, wherever you want. Some people get it from fat, controversial for many different reasons. And the third way to get it is, from the umbilical cord, placenta, and that's kind of not your own stuff though. So the best way to get a high concentration stem cells is really from the bone marrow. And this is also kind of pseudoscience-ish now. Lots of people are doing it. They're injecting in the body. You go to Mexico and get this stuff done. And this is a big claim. They're saying that it differentiates into this and you won't need, a knee replacement or anything like that. There is no evidence for that right now. But it does have applications that are beneficial in many other ways. Eventually in the future, we'll be able to inject stem cells into the pancreas. Let's say if you're having, you need something to replicate those cells, and you could heal a lot of problems. So people that have Alzheimer's, the dopamine centers in the brain are reducing. So you can replicate those cells. So this is the future. We're getting there. So we spoke about steroid, heat, electricity, platelets, and stem cells, where we put them, okay? With the X-ray machines and all the different medicines we can use. A few more things that are getting popular is this is an SI fusion, okay? So what we do is we take this little device. It's the size of about this big, size of a quarter, a little bigger, okay? And you take it, and so when people have sacroiliitis, or inflammation in this region, right? The first thing we do is we go in there. We can go into that spot, put in cortisone. We can put in platelets, all the stuff, electricity, everything I spoke about. But sometimes if it's bone on bone, and that's the most common reason when procedures, minimally invasive stuff doesn't work and you need surgery. Either it's bone on bone, the problem is too big for steroids or platelets or anything like that to handle. So this is a minimally invasive technique where we go in here and wedge that device. And it looks like that. So what it does is it goes in there and it opens it up. And it gives it some space and fuses it. So this is something that's become very, very successful for sacroiliac pain. And again, before we jump into this, we usually use steroids, maybe platelets, maybe heat around that area. It's called a SI ablation. So lots of choices. Another new technology coming out, it's very exciting, and we're going to start eventually doing this, is so one of the biggest problems when you're in pain is you're not using your core and the back muscles. These are called the multifidi muscles. They run from, so remember we spoke about the vertebral bodies were like bricks and we're laying the bricks one on top of each other. This is such a small muscle. It goes just from one brick to the other brick. So let's say you're in pain, the little muscles are the ones that go first. So these guys are gone, like in 3-4 days. The big muscles, like the rhomboids and the lats, those take a while. So most people don't notice it, but they'll say, you know what, I got an ache in my back. It's a stiffness. It feels weird. It's spasming. All of that's from these guys. So How do you strengthen the little muscles? That's really hard to do, which is why even with daily exercises, we want to do the right stuff. So this device is a stimulator. What it is you put these electrodes into this transverse process right next to the multifidi muscles, and it sends an electrical current to stimulate it. So essentially, we're strengthening the muscle and cheating, and you don't have to do anything. Well, you still have to do exercises, but it kind of cheats in the background. So we've spoken about a lot of different procedures, and I hope that, so my whole idea is to talk about the procedural aspect of things, but definitely realize that this is only one limb of all the treatments we use, and it's very important to use everything, not just one thing, to feel better. Thank you. Questions?
All right, we will open up for some live questions, but I got a couple first ones, which we can answer, and then we'll jump into live. What happens when the injections in the lower spine facet joint no longer work?
So a couple of different reasons why the injections in the facet joints no longer work. One, the joint space. Remember we spoke about it's a true joint, it's got a space in the cushion. If it's bone on bone, there's no room for the steroid to sit or the platelets or the stem cells to sit. So then we have a choice of ablation where we go around the joint and burn the nerves. And if that doesn't work, then we might have to use something, the stimulation we spoke about. So there are a lot of options if the steroid injection doesn't work. But remember, the facet joint is the only joint, one of the few joints that you cannot replace. If you have arthritis in the knee and the hip, it gets replaced, not the little facet joints.
All right, as a follow-up to that, it said, why would and I'm not sure I'm saying this right, but SI joint be injected when the, whoops, hold on, the question went away. Would the SI joint be injected when the SPECT scan showed it was the facet joints? So they have no relief of pain. In fact, it is worse.
So a SPECT CT scan is a form of imaging. What it does is it allows you to see the areas of inflammation, right? So when you see a SPECT scan, you can see the areas of inflammation, and you're supposed to inject that. So that's a good question in the sense that if you saw facet joints lighting up, we call it, or you look red on the scan, they put colors in. We know the facet joints are the problem, so you should be treating that unless the patient's body tells you something different. Like for instance, I'm examining somebody, and even if the facet joints light up and they don't have any pain there, you have to, there's one thing I learned a long time ago is listen to the patient, not the machines around them. So even if the SPECT scan, that's one reason they probably went to the other target.
Got it. And this one is one that we always have asked, but it can you do injections on a person who is on blood thinners, i.e. Eliquis? How long should a person hold it if you're planning to have injections?
So that's a good question. We get that a lot. So blood thinners, and why do we care, right? So now when we were looking at the original slides, if you remember that epidural space, it's crammed and really tight. It's surrounded by all these things, the dura and all that stuff. So if I go in there and I do an injection and you're on blood thinners and it bleeds, the blood doesn't have anywhere to go except inside, meaning it'll squeeze your spinal cord, which is not good. So if you're doing an injection in the epidural space, we have to stop the blood thinners. How long you stop the blood thinners is really determined not by any physician, but they had a symposium and a consensus, meaning a group of people got together, anesthesiologists and physicians, and came up with what's called the ASRA guidelines. The American Society of Regional Anesthesia came up with the guidelines. So if it's Eliquis, they say hold it for this long. If it's Plavix, you hold it for 7 days. So we follow their guidelines, but obviously we have to get permission from the prescribing physician, who is an expert in the patient. So we work together for that. There are lots of injections where you don't have to stop the blood thinners. Most joint injections we inject while you're on the blood thinners. The ablations, the facet injections, SI injections, hip injections, you can stay on the blood thinners.
All right, we have another, but let's jump to the room for a couple questions. And all I would ask is if we ask the question, maybe you can repeat it for people on Zoom.
Sure.
Go ahead and raise a hand if you would like to ask a question in the room.
Yes, sir. So the question is, what can you do for the curvature of your spine? So there are a couple of different ways you can have a curvature of the spine, right? So if you look at me standing this way, the low back curves backwards. That's called a lordosis. And up here, it bends forwards. That's a normal curvature. Now, some people can be bent down like that, okay? So hyperlordosis or flexion extension problems. Scoliosis is different. The scoliosis is not in this plane. It's this way where your back is twisted. So they measure the angle of the scoliosis or so this way, it's kind of like this, right? The spine's curved to the side. It's a very tough thing to fix if it's not done early on. So that's why everyone gets screened now in high schools. They bend them down and they get a little more aggressive now. Earlier, they never did this. They'd put somebody in a cast that never worked. But now they'll go in and do this massive surgeries with rods called Harrington rods to fix the scoliosis. And it does very well. But in an older person, the surgery is obviously a little risky, but you have to monitor it very closely, strengthen your muscles, and do everything else you possibly can. That's really the best way to handle that. But it is a tough situation if it's a significant scoliosis. Pain. Oh, okay. So the question is, what do you do if you've had a laminectomy? So a laminectomy is a surgery. So let me jump back here. Well, maybe not. Okay, so essentially, when we're looking at the anatomy video, the back, we had the facet joints connecting. That part of the back is called the lamina, right? So let's say that somebody had a very badly pinched canal and the injections are not working, nothing's helping you. Surgically, you can remove that back piece. It's called a laminectomy. And once you do that, the spine has more space now to breathe, and the narrowing or the stenosis is gone or reduced. So once you have that, typically it'll help with the sciatica symptoms, right? But we still have the same problems, muscles, and that's a big challenge. So when somebody gets to the stage of a laminectomy, it's even more important to do the lifestyle stuff and the exercises. So the way I approach that is I say, okay, here's the medicines, here's whatever you need. It's going to hurt. Initially, it's like you're going to the gym for the first time. And then usually if you consistently do the exercises for 6 weeks, it slowly gets better, but it's hard to get to 6 weeks. So you need the right medicines and need to do the right exercises. A lot of people, play golf or go to the gym, and that's not what you want to do. Simple things like pelvic tilts, lay on the ground, tilt your pelvis, flatten your back, basic leg lifts. Those are the most important things. And it's not, bench press and that kind of stuff. But it is a tough situation. But also remember, the cause of that laminectomy, the reason you had that was because of a pinching. And that could be because of genetics, injuries, activities. Those problems are still affecting your spine. So even though you have one laminectomy, it means you're at risk to have more back issues. And it is, so yeah, okay. Yeah, so once you go into the canal itself, right? So below the lumbar spine, exactly. So below the lumbar spine, it comes all the way. So the lumbar or the low back is numbered on the top L1, L2, L3, L4, L5. Around L2, you have this long tail of nerves. It's called cauda equina, horse's tail. What happens is when you're a baby, it's right at the very tip. But as we get older, it stretches. And that's why we have that. And that's why an epidural injection in the low back, anywhere below L2, is pretty safe, because if we go right through the cord, we just hit the sac of fluid. We're not going to cause a spinal cord injury. But if you're hitting the mid back or the neck, that's spinal cord injury if you don't do it right. So let me kind of translate this a little bit for everyone. So now we're going into the surgical world, right? So again, two big problems in the back. One problem is pinching. Other problem is arthritis. Arthritis is a whole different world. And so we're talking about pinching or stenosis. When somebody has a pinching in the canal, you try all the conservative things, injections, all that kind of stuff. Sometimes the problem's too big. So the first thing they would do is remove the hood, which is a laminectomy. But sometimes that's not enough. Then you can actually fuse the two bones. You put metal. Earlier they used to use bone grafts, but limit those segments from moving. That's called a fusion. But once you put metal in two segments, the segment above and below has to work a little harder, right? And when that happens, those segments get disease, arthritis and whatnot. So what she's saying is that the doctor went into that spot and couldn't put any medicine in there because that segment was very, very stenotic. And so that's the thing. When you go back to saying, okay, why did that first segment need a fusion? Because most people, but a good chunk of people, we do a couple of epidurals and they do well. There is a genetic component, activity component, all the things you did in your life to affect that one segment, it's affecting the whole spine. So that's why that upper piece probably still had some stenosis, unfortunately.
So, next step.
It depends. It depends. I mean, I have to look at all your stuff, but may need another surgery. Hopefully not. But I mean, the platelets stimulation, because you don't want to put in stimulation if there is an actual mechanical disease. Stimulation is reserved for things that you've already fixed. That's good. So the question is osteoarthritis knee and Supat's gel. So again, this is going back to my lectures. It's a joint problem. The joint has lost its space, so it's arthritic. Yeah, so the first thing we do is you go in and put steroid, maybe it didn't help. The next step we spoke about is platelets, stem cell, all that is available. But in the US, it's authorized to do a viscous gel, and that's called Supats. That's a great option. Some people do very well with it. So you can go in there and put this gel. In Europe and some of the countries, they inject shoulders and all that with it, but it's authorized only for the knee in the US, and it's a good option. It helps. Yeah. Questions?
All right, so we'll take a couple online here. So a very long question, but one of the general is that in regards to steroid injections, epidural space, and the FDA approvals, insurance, all that kind of stuff, it says the FDA warned of risks. Can you comment on the risks of steroid injections overall? And does insurance companies or Medicare approve off-label?
Good question. So the first thing I have to say when we talk about the healthcare system is we have one of the best healthcare systems comparatively, right? Like, I mean, in third world countries, it's a very different system. So we have a good system here, but it's a complex system, complicated, meaning you have to get entered into a system. We have to get authorization. And, before you get an ablation, you need all these to, trust me, we hate it too, okay? It's frustrating for patients because you're in pain. You want to get things fixed, but we have to go through these steps. So steroids by themselves, if you do too much of it, it's a problem, right? So you have to monitor it very closely. You can have a lot of steroid because it's stuff created in your own body. So it's safe. But if you do too much steroid, let's say in a soft tissue, like, let's say the shoulder or muscle, it can damage the muscle. That's why people are going in and preferring platelets and stem cells into soft tissues and joints. Epidural space, you're fine because there's, like I said, there's an empty space in there and you can put a lot of steroid. But then if you put it too frequently, it's not going to damage the epidural space, but you'll get side effects of steroids. Remember I said if you take it by mouth, you're going to get a lot of side effects? Same type of thing happens if you have a ton of steroids in the epidural space. You can have about 4 or 5 in one region per year. Did that answer the question?
That's good. One last one on this, and then we'll open up for more. It says, is any form of anesthesia used for heat or electrical procedures?
Yes. So before we do any injections, we always use, I use a spray. We use topical lidocaine, and you wait a little bit for it to take effect, and then you do the procedure. Some practices for heat, they use local. We do it with local as well. We do. So for that, I use 2% and bupivacaine. So a lot of local anesthetic and oral sedation, but we also do propofol type stuff to put people to sleep. But what you're describing, when you have sciatic pain and it's going down your legs, it might be a different problem. It might be a pinched nerve. So we might have to get some imaging and all that stuff and reevaluate. Just send me a message on my chart. If not, they'll make you wait a long, long time. So.
Perfect. Thank you so much. Thank you so much, doctor.
You're welcome. Nice to hear your voice.
All right, let's go back to in room. More questions from the audience here?
Correct. So stem cell and platelets are not covered. And some people, that's the problem. So I told you stem cell was eventually going to make a big difference. But a lot of people are doing this weird thing where they're charging 20,000. Like it's kind of a little bit of a racket. People go to Mexico and do it. So pretty soon the FDA is going to start, monitoring it. But stem cell and PRP is typically not covered. Yeah, so good question. So spinal decompression, couple of different ways to look at that word, right? So remember, again, in my picture, we spoke about the bricks laying on top of each other with the disc in between. So to decompress the spine, what the chiropractors are doing is they put you in a machine that stretches you, right? It's like a traction machine, which is good. But evidence has shown that once you stop stretching, it go back, right? But what that does do, though, is it loosens the muscle. So it's like a really expensive stretch. That's pretty much what you're getting. Mhm. Depends on what machine they use. So there's a surgical decompression. So decompression is relieving the pressure, right? So when you do a laminectomy, that's a surgical decompression. You're actually taking a piece of the bone away. And a fusion is also decompression. Yeah, so that will last a lot longer than obviously the traction device. Yeah. I mean, some people, see, the thing is that some people come to me and have had decompression and,
Because you already changed some.
love it because it's just stretched their muscles. But I tell them, were you stretching before? They're like, no, this is great. Well, but it's expensive. You can do it at home. Yeah. Yeah, yoga. So now we're talking about a comprehensive treatment plan, and we're talking about yoga. Yoga's gentle, exactly. So yoga I like as long as it doesn't go to the end range of movements. Especially if someone has done yoga their whole life, they can do things that, I mean, nobody can do. It's pretty impressive. But if somebody new goes into yoga and tries that, they're going to get hurt. Exactly. You got to find a good teacher. Exactly. And that's a very good point. Good teacher. And that's the same thing with physical therapists too. Some people go to a physical therapist, terrible experience. Different therapist, great experience. So that's the one thing that's hard for us to control because it's just hard to control. But you're right. A good teacher will make a big difference.
All right. A joint question. Joint humor. Sorry. First question is, are you taking new patients? And then the second part of that is, if I get an authorization to go out of network for my insurance to see you.
So, I mean, I do, but the beauty of it is we're getting more people into our group. And even if you can't see me, you can see one of my colleagues, and we have meetings every week. So we do pretty much the same kind of stuff as a group. So even though I'm up here and you try to see me, if it's a long wait, we have Dr. Patel, we had a new guy, Dr. Shah, coming in, and I trained them all. So you will get the same type of treatment within our group. So that's kind of a yes and yes, but we'll figure it out.
Absolutely. And I think that is the key to almost anything within Eisenhower is get on the wait list, get on a call, do my chart.
Exactly.
Talk, get an appointment if you can.
Agreed. Some insurances need referrals, some don't. But I think Medicare does not, so we'll be okay with that.
But if you call Desert Orthopedic, they will be able to tell you most
you.
likely the front desk.
Just send it. I mean, if you have problems, just send a message through my chat. No, send a message, we'll get you in. Yeah, we have a lot of slots and availability to work patients in. It's all the other stuff. So a lot of good question. Any recommended courses online? So we work a lot with the Eisenhower Physical Therapy Department, and we're putting some videos together. But a lot of the stuff that they have on the Eisenhower website is good as general stuff. And Eisenhower does, and Brett could probably answer this question. They have a lot of programs that are really good.
Absolutely. And to that, you can find, which I'm glad we'll close out on that note, actually, because we're at time. But all of our, like, this is being recorded. So in case you want to get further in the weeds on it and look at it again and review, it will be on within the next couple of weeks. We edit it. It's on our Eisenhower Health YouTube channel, which you'll be able to very specifically look at desert orthopedic, cardiovascular, cancer, all of our general lectures by year. We're on there with all of that, some podcasts very specific about certain conditions. But to your point about physical therapy, if you look back to 2024 and 2023, specifically, we have multiple different lectures on, basically we break them up into 3 body parts. Like neck or head to waist, and then waist to knee, and knee to foot kind of thing. So there's a lot of stuff out there for content, and that will also then give you an indicator of some of our physical therapists and occupational therapy. And with that, Dr. Cassim, any last comments or words?
Well, I wish you the best and life pain-free, and thank you for coming out. Good to see you, familiar faces, and thank you very much.
And I believe, Dr. Cassim, can you say, where can you get your book?
It's
We're not supposed to say that, but I love the book, so I'm going to say it.
it's on Amazon. It's Amazon.
Amazon.
Live
So if
Life
you
Paid
liked
Free.
it, definitely check out
Live
Dr.
Life Paid
Cassim's book.
Free, yeah. Express.
All right. Well, thank you all very much.
Thank you, guys.
And we're off soon.
Thank you.